So did you know that about 80 to 90% of dry eye cases also have signs of what is called Meibomian Gland Dysfunction, otherwise known as MGD. This is where tiny glands in our eyelids, when we blink, they're supposed to secrete a very thin oil that helps stabilize our tear film and helps prevent it from evaporating. But unfortunately, these glands in our eyelids, they can start to have some sort of dysfunction. They stop secreting, or the quality that comes out of these glands is very poor, and this causes a lot of issues. So with how frequent we find these cases of MGD, we have to understand this. So in today's episode of the Dr. Eye Health Podcast, we're going to be breaking down exactly that. We're going to talk about what is MGD, we're going to talk about the pathophysiology, what causes Meibomian gland dysfunction, and then ultimately even what type of treatment options doctors are frequently recommending for their patients to do for at-home therapies and treatments, but also what is offered through prescription medications and in-office procedures. First, if you are new here to the Dr. Eye Health Podcast, my name is Dr. Joseph Allen, and I'm a board-certified doctor of optometry who also does a lot of treatments and focus on anterior segment and dry eye. If you're new here to the Dr. Eye Health channel and you value evidence-based education and information about the eyes, vision, and taking care of your overall well-being, then welcome to the channel. Consider subscribing and following. Today's episode is sponsored by Cequa, cyclosporin ophthalmic solution 0.09%. Now, I think it's important to know that if you ever speak with your eye doctor about dry eye, they may advise about starting a prescription eye drop medication such as Cequa. Cequa works by increasing natural tear production, helping the eyes produce and maintain more of their own natural tears. Its common side effect includes installation site pain and redness, and to avoid injury and contamination, don't touch the Cequa vial tip to the eye or other surfaces, discard immediately after use, don't use Cequa with contact lenses, and wait 15 minutes before reinserting. We will talk more about the clinical trials and the efficacy of Cequa later in today's episode. Otherwise, visit Cequa.com to book a virtual appointment or find a doctor near you. Okay, so let's dive into understanding Meibomian gland dysfunction, or MGD. If you are able to look into the mirror and pull down your own eyelids a little bit and look on the inner lining, if you're lucky, you may see some small vertical lines in those eyelids. Those are the Meibomian glands. Now, sometimes this can be difficult to visualize, and in the eye clinic, we have an instrument called a meibographer, which uses infrared light to take these morphological images so we can see how many glands there are in the eyelids. We can also see if they're inflamed, if they are truncated, or meaning there's kind of a dark line that goes through them, or they're segmented. But you can also see if some have atrophied and have gone away for some reason. Now, there's about 20 to 30 of these Meibomian glands in the lower eyelid, and about 30 to 40 of these glands on the upper eyelid. In the eye clinic, we oftentimes always visualize at least the lower eyelids. I will say I find a lot of value as an eye care professional of also imaging the upper eyelids, because sometimes a patient may come in and all of their glands on the lower eyelid have atrophied and gone away, but if we flip the upper eyelid, they still have several glands there. And so that does tell me not only how many glands there are, but how high risk this patient is of it kind of going further, but also gives me more of a history of what could be going on and their risk. So with these oil glands, as mentioned earlier, every time we blink, a little bit of oil comes out. So when a young, healthy individual comes in and they're blinking during a normal exam, or if I just gently touch on their lower eyelid and apply pressure, this soft, clear oil comes out. And that oil comes out and mixes with the tear film. Now, a lot of times in illustrations, we show this lipid or this oil coming out as yellow. And in a healthy individual, it's not really even yellow. It is a clear liquid, and it mixes with our tear film and helps prevent it from evaporating. It also helps stabilize the tear film so that when there is irregularities between blinks, if there's a foreign body, if there's something changing with the tear chemistry that's interrupting the ocular surface, the oils create a higher viscosity that stabilizes that tear film and prevents it from having shearing stress and separating. And again, just as a reminder, for those of you who don't study the tear chemistry as often, just remember the tear film is not just water like tap water or bottled water. The tear film is a mix of electrolytes. It has proteins in it. It has antibodies. It even has some vitamins and minerals in it to help bathe the ocular surface, to help contribute oxygen and give it the proper nutrients it needs for the cornea and the tissues around the eye to stay healthy and fight off microorganisms and potential damage from everything in the elements. Now, this tear film is only stable when it has this healthy meibum, this healthy oil that's being released. Now, in somebody who has inflammation or changes to these oil glands, then suddenly it's not functioning the way it should. So here I'm showing an image of somebody maybe looking in the mirror. It's almost impossible to look in the mirror and tell if somebody has Meibomian gland dysfunction on their own. It's often something we need a microscope, you need high-powered magnification to get a better view of what's really going on microscopically on the edge of that eyelid. So here I have an image of a patient of mine. She was actually in her young early 30s, and you could see, just observing in the image that we have here, it's an edge of an eyelid. It has a lot of kind of oily kind of substance along the eyelid margin and even in some of the eyelids. The eyelid itself also is not just, this is a Caucasian patient, but it's not just like a kind of a Caucasian colored skin tone. There's a lot of these small blood vessels mixed throughout. In fact, they look irregular, and those are a sign of what we call telangiectasia. They're basically kind of like spider veins on the surface of that eyelid. And that happens in response to chronic inflammation. The immune system recognizes there is damage, or there's a foreign invader, or there's something irritating that tissue, and it's trying to send immune cells to try and heal and basically improve the health of that area. Unfortunately, those new spider veins, telangiectasia, are a bit leaky, and they often transport a lot of immune cells to that area. Now, on the back side, something that I also observe is that kind of toward the top of the eyelid image, there is a heaped up appearance. It's irregular, and we call that having a keratinization. It's basically a more thick, fibrous version of epithelial tissue that's kind of building up on itself. And then you can see these little yellow, you could say it looks like a deposit, but you can see these yellow pus sort of nodules in the middle. Well, that yellow pus nodule, I'll call it, is in fact the Meibomian gland that is either obstructed, or the oils that are coming out of that gland are inflamed. They are not a clear oil. They are a yellow, almost pus or waxy substance. And so something that we do in the eye clinic is we touch the lower eyelid, we push on a little bit, or we use a specialized forceps tool to squeeze the glands gently, to squeeze the eyelid to see if we can get those glands to express. And we call that Meibomian gland expression. Now, I'm going to be showing a video here of that procedure that I've done on a patient, and I want to be able to show you what it looks like when we see these oils that are thick and they're coming out more like a waxy substance. Now, I give this warning before I play it, because for all of our viewers who are either squeamish, they don't like looking at the eyes, this procedure has no blood in it. It is, it's very kind of just mild to watch, but I know some people are upset by it, so if you don't like to watch it, you can always skip forward. But this is the Meibomian gland expression procedure. And again, clinics will use this to not only get an assessment of the oils that are released, but we'll often use this even as a therapeutic treatment to express those oils so the body can produce some of its own normal oils again. But you can see what's coming out is thick. It is a dark yellow color. Sometimes I've heard some providers describe it as like a thick American cheese kind of color, or even a thicker wax type of color. Now, why this is significant is because if the oils that are coming out of the eyelid are irregular, then we can't expect the tear film to be that stable. And so now what we're seeing, I'm in fact showing a video of a patient blinking, and the eye looks green because in the eye clinic, when we assess for tear film stability, we put a yellow stain on the eye called fluorescein sodium. But that yellow stain, we highlight with a blue colored light using a cobalt blue filter, and it highlights that stain. So if there's irregularities in the tear film, or if somebody has scratched their eye, or if there is a viral infection of some kind, we can often detect this irregularity on the surface, and that'll help us confirm a diagnosis. Now, here, what we don't see, thankfully, any scratches or anything, any viral infections, but what you can see is the tear film is very thin, and in between blinks, you'll start to see this dark area sort of appear right in the middle. And this is where the eyelids, or I should say the tear film, starts to separate, and you start to have this area where the epithelium underneath is starting to be exposed to air. And so this procedure we'll do in the eye clinic to measure the tear film stability. We call this a tear breakup time, or a T-BUT score. And so we'll ask patients to blink, and then we'll count in our heads or out loud. The doctor will count how long it takes to start seeing that black thin area appear. So we can do this ourselves in between the blinks. As soon as this patient blinks again, now we'll count 1, 2, 3, 4. And about 3.5, 4 seconds, you can start to see that dark area separate on the surface of the eye in this video. And so this person would have a tear film breakup time of about 3.5, 4 seconds, which is significant for this tear film instability and likely associated with Meibomian Gland Dysfunction. So that's what we measure in the eye clinic. Doctors are evaluating for not only the inflammation and the expressibility, and is oil coming out? How thick is the oil? Is it expressing very well? How many glands are there? Have they completely atrophied away for some reason? And then we're measuring how stable that tear film is. Now, the symptoms of Meibomian Gland Dysfunction, or these MGD symptoms, they're very similar to just normal dry eye. I say normal dry eye, like any dry eye is normal, but dry eye syndrome and the symptoms of dry eye syndrome are basically overlapping exactly what we have with Meibomian Gland Dysfunction. Oftentimes there's an irritation or foreign body sensation people express. The eyes, they'll say, will feel dry. The eyes and the eyelids may appear red with dilated, very prominent blood vessels on them. They'll describe eye pain or irritation, or even eye fatigue, or their eyes feel tired, especially at the end of a long day in the afternoon. Some people, paradoxically, will also mention that they don't have dry eye. Their eyes are instead wet, and their eyes tear frequently throughout the day. And let me know if you've ever had that before. Please leave us a review or put it in the comments if you've ever felt like, no, my eyes don't feel dry, they feel wet frequently. Because eye doctors, we hear that all the time, and it's sometimes a tough thing to describe, but it's part of your body's own reflex to try and correct the problem itself. Because if there's something that's irritating the eye, if you have tear film instability, you're having these moments of dryness, of damage that may be occurring on the eye, and something's irritating the eyeball, and so the body recognizes that and does what? Like if you have a lash in the eye stuck on the eye, or a piece of dust, the body makes more tears and you blink more frequently because you're trying to flush whatever's stuck in there and get it out. Well, when you have dry eye, your body is also responding to that same sort of irritation, so it's making more tears in response. And so we call that reflex tearing. The other symptom that I think people often kind of confuse or don't recognize is a symptom of dry eye is blurred vision. And I sort of have an image of somebody with all these letters around them, and they can't quite see things. So a lot of people will come in because they feel like their glasses or contact lens prescription's off, they can't see as well, but in fact, the glasses prescription will be dead on, or the contact lens prescription will be correct, and the contact lens will be stable and a good fit, but it's the tear film that's irregular. The first interface, refractive interface on the surface of the eye, where light is traveling through the air of the room or the outside, it comes and interacts not with the eye, it actually interacts with the tear film first. And so the first point where the light starts to refract or bend to focus inside the eye and give us clear vision is the tear film. So if the tear film's irregular and not stable, then you're going to have blurred vision. I'll have patients who normally see 20/20, they have excellent vision, then because of their significant dryness and MGD and everything that's going on, they'll be like 20/60 I've even had patients up to 20/80 because the ocular surface is so beat up and so irregular from their dryness that they're not even legal to drive and hold a valid driver's license in the state during that time. The other symptoms that some people don't think about that are also related to dryness and meibomian gland dysfunction can be light sensitivity and glare for the same reason. As the tear film becomes unstable and the surface of the eye becomes beat up, regular, or damaged, there can also be light scatter inside of the eye, and then that contributes to glare and light sensitivity. Now, an interesting statistic, as I was reviewing things over the last few months, whenever I do an education, I like to dive deeper into what's in the current research. Is there something new that I haven't read, new theories? And a statistic that I saw that I found really fascinating was just published here in 2026 from Frontiers of Medicine. It was a systematic review. They found that more than 70% of cases of meibomian gland dysfunction are asymptomatic. That means the vast majority of the people who have meibomian gland dysfunction do not feel the symptoms, or it could be that they have very mild development of meibomian gland dysfunction, right? They have early stages of the disease and they haven't felt the ramification. But I will also toss in there, out of my own personal experience in the eye clinic, that a lot of people have the symptoms of dry eye and meibomian gland dysfunction, but they don't recognize that those are symptoms of that condition, or they have normalized those symptoms in their daily routine, right? It's kind of like buying new shoes and you expect that those new shoes are going to be a little tight the first few times you wear them. Or if you stand for work all day long, at the end of the day, your feet may feel a little sore, and you may normalize that. Well, yeah, you've been standing on your feet all day. Well, with the eyes, we often feel irritation, redness, kind of that tired eyes feeling toward the end of the day. Well, if that becomes your normal, then you don't even recognize that what's going on is like abnormal, right? So I think for a lot of people, their asymptomatic dry eye or asymptomatic meibomian gland dysfunction is in fact somewhat related to them just normalizing these type of symptoms. Now let's dig deeper in understanding why. Like, what causes meibomian gland dysfunction? What is the pathophysiology? What is going on in the first place? Like, why are people suffering from this? Why is this playing such a big deal? So there's different theories that kind of go into this, but the two most prominent are morphological changes that we see on the surface of the eye. One is hyperkeratinization of the ducts. Again, these are glands that if the duct itself becomes blocked up, so the epithelial cells start to become fibrous, they become a more dense, thickened type of cell, and they clog the gland duct itself, or they cap it off, they block it from releasing. And I heard another eye doctor friend of mine call this as being constipated. The oil glands are constipated, they are blocked up. And if the oils are still being produced underneath by these glands and there's nowhere to go, then the pressure inside the gland builds up. And this increased pressure may cause damage and atrophy of the meibocytes underneath. The other component is not just how much oil is getting out and actually getting into the tear film, it's the quality of the oils that are coming out. And so we do also recognize there is alterations in meibocytes and the cells that are producing the oils within the glands. And this often is that the oils are not that thin, healthy oil. Now they are a more mucousy, inflamed, darker yellow colored, almost wax-like substance. Either way, though, there's a strong relationship between the two, and eventually it leads to not only hyposecretion, so very little secretion of oil, but then the quality of those oils is very poor and, again, doesn't have the same viscosity or stabilizing effect that we typically see with young, healthy oils. Now, that's just pathologically what we see observing changing within the gland itself. But if we dig deeper than that and kind of question, okay, well, what is really associated? What is maybe contributing or causing these changes to the glands, whether it be hyperkeratinization or changes to the meibocytes? What's going on? There's many things published in the literature. I'm just going to review some of the most common ones and give context to it because I think it helps us better understand not only what is going on or what's going on in our life that maybe caused meibomian gland dysfunction to happen in the first place, but it also gives more meaning and reasoning behind what treatment options doctors often prescribe or recommend for their patients. All right, now let's take a moment to share more helpful information about the prescription dry eye medication, Cequa. Cyclosporin ophthalmic solution, 0.09%. Cequa comes in a single-use vial and is used by placing one drop in both eyes twice a day, approximately 12 hours apart. Cequa was studied in 2 clinical trials totaling 1,048 people with chronic dry eye. In both studies, significantly higher percentage of people treated with Cequa achieved a clinically relevant improvement in tear production compared to those not taking Cequa, approximately 17% versus 9%. And out of 524 people treated with Cequa, only 162 reported side effects. And of those, most reported only mild side effects. Of note, 95% of patients experienced no or only mild installation site pain. 99% did not experience blurry vision after using Cequa, and 100% of those did not experience any bad aftertaste. Again, the most common side effects include installation site pain and redness. To avoid injury and contamination, don't touch Cequa vial tip to the eye or other surfaces, discard immediately after use, don't use Cequa with contact lenses, and wait 15 minutes before reinserting. Now, because there are many factors to dry eye, Cequa may not be for everyone. So as always, talk to your eye doctor and ask if prescription Cequa is right for you. Don't wait to get relief. Talk to an eye doctor today. Visit Cequa.com to book a virtual appointment or find a doctor near you. First one is age, and I know hearing that everyone's it's kind of a groaner, right? Nobody likes to hear that any sort of disease process occurs just due to age. I like to dig deeper and think, what is going on with age that causes these changes? So 2 things I'll mention. One is that histopathological studies do show that in both humans and in some animals, like in mice, that the hyperkeratinization of the duct being blocked, does not occur naturally due to age, but the alteration of the meibocytes do. And that, at least to me, and several other eye doctors who specialize in dry eye, we have these conversations frequently. We often do think that there is a change with our hormones with age that likely has a role with these meibocyte changes. There could be a lot more going on, but those are some of the kind of thoughts and discussions that we have kind of behind the doors. Beyond these aging changes, because we can't control age, there are other things that we do have a little bit more control over. This other part that comes up is blinking changes. Again, when we blink, and we blink completely, this small muscle of Rylon, some doctors will call it, this small muscle squeezes the duct of the gland, and that encourages the oils to release when you blink. The challenge is that when we're in front of digital screens, whether it be your phone, a tablet, computer screen, which all of us are in front of all day long, our blinking patterns change. In fact, in a normal conversation, our blinking pattern can be anywhere from 15 to 20 times a minute, but usually when we're staring at a screen, it can drop to 7, even lower than that to like 4 times a minute. So we're blinking essentially 75% less often. On top of that, we tend to blink incompletely. And if you're checking us out again on YouTube, I have some videos going on right now from older videos of myself demonstrating what this looks like. So we often do see people, even in the slit lamp at the eye clinic, we can detect and notice that when they blink, their eyelids only closing about halfway, covering their pupil. So the brain thinks, oh, light shut off. I blinked all the way. But in fact, the upper eyelid and the lower eyelid never came together. They never fully blinked. And so those muscles of Rylon may have never squeezed to release much oil in the first place. And so that becomes a concern that perhaps if the oils are not being encouraged to release, then that's not pushing any of these like dead epithelial cells out of the duct. And so that might be one of the reasons why hyperkeratinization is occurring and these ducts are becoming blocked up with meibum. Now, the research on what significant role blinking patterns change affect meibomian gland dysfunction and the risk for it hasn't fully been like shown yet. There's still a lot of research going on, and right now the data is a bit mixed, so we are waiting for more research to be published on that. Systemic diseases are often associated with worsening meibomian gland dysfunction. Some of the most notable ones I have here is thyroid disease. Thyroid affects the body in many different ways, but there are published studies that show that worsening levels of thyroid, so someone who has more severe thyroid dysfunction, they're at higher risk and have greater disease severity of meibomian gland dysfunction than people with just mild thyroid dysfunction. People who have metabolic syndrome, whether it be problems with high cholesterol, dyslipidemia, diabetes, high blood pressure, they have an increased risk or association with having meibomian gland dysfunction. Again, changes to hormones is also known to play a big role. So menopause, perimenopause, and androgen deficiencies all have been found to have altered meibomian gland dysfunctions. In fact, women having to go through menopause and perimenopause, we have also seen that women tend to get worse dry eye symptoms and signs about 20 years ahead of most men. Of course, there's always exceptions to that rule, but that is a general trend that we do observe in the field. So there is some thought that perhaps hormone changes due to menopause and perimenopause could play a more substantial role in this. Skin conditions also play a significant factor. The two most notable ones are that of rosacea and seborrheic dermatitis. So both inflammatory conditions that affect the skin. People with rosacea also usually have kind of rosy cheeks, right? Easy way to remember it. These are irregular blood vessels that show up on the surface of the skin, on the nose, the cheeks. They can form on the eyelids. And when this occurs, we also often diagnose what is called ocular rosacea because we see a lot of these spider vessels, these telangiectatic blood vessels on the surface. The seborrheic dermatitis, we often see this as an inflammatory reaction of oil production in oil-producing areas of the skin. The big common one is the scalp, and this is sometimes due to the presence or a hypersensitivity to certain yeasts and fungus that can take hold in some areas of the skin. And so some treatments for seborrheic dermatitis, in fact, are using like antifungal medications, shampoos, and the like. What is interesting, and we haven't mentioned so far, because most of the cases of meibomian gland dysfunction, we think of having hyposecretion of the meibum, but there are cases where people have hypersecretion of meibum. It's not fully understood. It's not a whole lot of cases that's reported, but the two most common conditions that may cause hypersecretion are associated with rosacea and seborrheic dermatitis. However, I will also mention both rosacea and seborrheic dermatitis are also associated with hyposecretion, probably due to chronic inflammation leading to meibocyte changes and gland atrophy. The other list I wanted to include here are some medications. The most famous, I feel, in the eye care field is that of isotretinoin. This is an oral high concentration or cousin of vitamin A. It's often used to prescribe for people with cystic acne. And this is famously connected to significant and rapidly developing cases of meibomian gland dysfunction. Finasteride, this is often used for baldness for some men, as well as prostate hyperplasia or growth of the prostate. And so this one, I'm seeing more recent publications coming out connecting finasteride to meibomian gland dysfunction. Some antidepressants and also chemotherapy agents I wanted to include in here are also associated with a lot of gland atrophy. And this is something I just like to mention. So if you're listening in and you've gone through chemotherapy, or maybe you're a family doctor, if you're a PCP, or even if you're an eye doctor yourself, if somebody is going through chemotherapy, know that dry eye, not just meibomian gland dysfunction, but dry eye in general is common with that type of treatment. And I would say just consider, for most people, even just getting a few eye drops, 1 or 2 eye drops a day would be a very nice thing. Just artificial tears to lubricate the eyes, because we know they're likely going to experience some form of dryness. But I would suggest for any family doctors out there, or if we have any oncologists or somebody who works in those clinics listening in, I do encourage you, do recommend patients to seek care from an eye doctor, or hopefully even a dry eye specialist if they are going through something like chemotherapy, because it can also obviously affect dry eye and the ocular surface. Other medications, especially in the eye care field that we know, are that of glaucoma medications. They are been strongly associated with meibomian gland dysfunction, and some preservatives, even ones used in medications and artificial tears. Most notably is one called BAK, or benzalkonium chloride. Now, BAK we've talked about in previous podcast episodes and other videos here on YouTube, but BAK is a great preservative. It's very efficient, and it's cheap. It works in very low concentrations, but even low concentrations of BAK, some people can have allergic responses to, but it's put into most forms of eye drops, both prescription and even artificial tears that people are using for symptoms of dry eye. And this BAK has been found to destabilize the tear film, to alter the nerves on the eye, and even cause interruption of meibomian gland and leading toward meibomian gland dysfunction. So there's a strong association there. So that is why eye doctors now, especially in the field of dry eye and ocular surface disease, often do recommend people focus on using preservative-free artificial tears and focus on using those ones. Now, there are some other things I want to mention that are commonly associated with meibomian gland dysfunction, is cosmetic use and eye tattooing. Again, women tend to tend to wear makeup more often than men, and women do tend to get dry eye more often than men as well, by about 20 years. But cosmetics is implicated in some of this. There's a lot of research coming out. We did even have a previous education and deep dive with Dr. Laura Perriman a few years ago, because she's a great, not only dry eye expert, but she also has extensive knowledge in the world of cosmetics and certain ingredients that may not be as eye-friendly or eye-safe as what previously was thought. And these are attributed to not only dry eye symptoms, but could contribute to meibomian gland dysfunction. And we'll put links to that conversation and education in the show notes if you want to learn more. Contact lens wear is also associated with changes to the meibomian glands. It's not entirely clear why contact lenses may contribute to meibomian gland dysfunction. We're not sure if it's the interaction between the contact lens and the eyelid. Is it because of changes in blinking patterns? Because we do tend to see more incomplete blinks with contact lens wear as well. Or is it because with more dry eye symptoms and irritation from contact lenses and the tear film interactions with contact lens wear, is there more inflammatory proteins building up in the tear film and resting on the eyelid, and is the presence of those inflammatory proteins contributing to meibomian gland dysfunction? It's not fully clear in the research yet, but again, that is something that's being looked into. But in general, this idea of chronic inflammation is something I've mentioned several times throughout this whole education. And so chronic inflammation is likely contributing. These new immune cells that are getting in contact or going to this area likely are contributing to these changes in the meibomian glands. Some of the most notable kind of causes or relationship that are associated with chronic inflammation is people who have atopy or just chronic allergies, because the immune system's often kind of over-primed in chronic allergies, as well as autoimmune conditions, to be hypersensitive to either the environment or certain allergens, or just we have a higher amount of highly triggered immune cells throughout our body, especially in autoimmune conditions. And then another eye diagnosis, another condition called Blepharitis. Now, if you've never heard of blepharitis before, we've talked about it a few times here on the Dr. Eye Health channel, but blepharitis is a diagnosis where there's inflammation of the eyelid skin, the lash, and the lash follicles. That's kind of the easiest way to describe it. This is often seen in individuals who have a lot of either dead skin, oily skin, such as with seborrheic dermatitis. They often do have an overgrowth or a hypersensitivity to the presence of microorganisms, especially that of Staphylococcus aureus, which is found the most common. Staph aureus is a common bacteria found in the skin. About 30 to 40% of everybody just has it on them. But some people, again, may be hypersensitive to it. So if there's a buildup of this kind of microorganism presence on the eyelids where there's moisture and oils and nutrients, all of these things, then people can have this immune response to it. And so then again, the eyes and the eyelids look red, inflamed, and they may be irritated. And so when somebody has chronic blepharitis, this chronic inflammation is there on those eyelids, and that may contribute to Meibomian gland dysfunction. One thing that's getting a lot more attention now these days is the presence of Demodex mites. If you've never heard of this, maybe you've seen things on social media about it, but there is a mite that it's microscopic. It lives in our lashes and in our hair follicles. So this mite, I will say to anybody who doesn't like insects, we know there's microscopic dust mites that live everywhere around us, and they live on our skin. They eat dead skin cells and oils, and they live as part of our normal flora. They live in harmony with our bodies. But some people either have an overgrowth or a hypersensitivity to the presence of these mites, or perhaps their waste or other enzymes that are associated with it, or other vectors that they bring along with them, right? Other microorganisms that may come with them. So in the eye clinic, we often do recognize something called as Demodex collarettes or eyelash collarettes. So at the base of the eyelashes, we're not talking about the Meibomian gland right now, we're talking about the eyelashes, but the base of the eyelashes, we'll see this buildup of kind of this yellow waxy appearance. And that is more or less bodily waste of these small microscopic mites. When I say they're microscopic, I mean you cannot see them with the naked eye, even under the magnification we traditionally use for our microscopes at the clinic. So like the images we're showing here, you can see the yellow buildup at the base of the lashes. Those are not the mites. In order to see the mite, you need to plate it and look under a high-powered microscope. And I'll actually show what it kind of looks like in this next image here. So these small little mites, they live in the hair follicles, and usually we'll find anywhere from 10 to 25, potentially more, if you ever pluck an eyelash and test it and plate it, you might be able to see quite a few in there. But again, some people may have more, and some people may be hypersensitive to them. So we call this Demodex blepharitis. And there's two different ones. There's Demodex follicularum, Demodex brevis, but these are known to trigger inflammation. They are strongly associated with rosacea. In fact, you won't just find these in the eyelashes. You'll find them in other small, similar, like small hair and oil follicles throughout the face, and even sometimes the back of the neck. But they are associated with thinning of the lashes and misdirected lashes and lash loss. It's again, same other symptoms: red, inflamed eyelid margins, itchiness, burning sensation, crustiness of the eyelids, and symptoms of dry eye and fluctuating vision, which go hand in hand with things like dry eye and Meibomian gland dysfunction. Now, I mention this because there is a strong association between developing Demodex blepharitis and seeing other signs of Meibomian gland dysfunction. And so a lot of eye doctors are now, when we recognize signs of Demodex, we are trying to treat it earlier and be more aggressive about it, because there is this concern that downstream we may end up seeing more problems with Meibomian gland dysfunction. Now, we've covered quite a bit so far in the education, but let's talk more about treatment, because we understand more, okay, what's going on? The glands are getting clogged. The oils that are coming out are very poor quality. And you may be thinking, okay, my doctor, maybe if you're listening to this and you're thinking, okay, my doctor mentioned Meibomian gland dysfunction to me. I want to better understand what it is, but I want to know what needs to be done about it. Like, what options are out there? So let's talk about treatments. kind of the basic treatments, the most essential ones that doctors often do recommend for patients to do at home include, one is just eyelid hygiene. Most people don't learn to clean their eyelids or eyelashes on a regular basis, right? We often learn to brush our teeth every day, at least once or twice a day, and floss every day. But the eye care field has never really, I think, done a best job of promoting better care of the eyelids and eyelashes. The methods that are used, there's several different out there that's published in research, in different books, but what is often recommended now by a lot of professionals is just to clean the eyelids either with pre-moistened eyelid wipes that are wet and soaked with a type of eye-friendly eyelid and eyelash type of shampoo that usually doesn't cause much irritation or tearing. These often do contain either ingredients like tea tree oil, manuka honey, hyaluronic acid, chamomile, or okra. And it's often including these type of ingredients because they're not only soothing to the eyelid, they may help with anti-inflammatory, they may have anti-inflammatory effects, and they may have some antimicrobial or antiviral or antifungal type of effects. This is either in a pre-moistened wipe, there's foaming cleansers that some doctors recommend, and then there is a type of facial cleaner and eyelash cleaner called hypochlorous acid. Sometimes that's recommended as well. One additional step and benefit of cleaning the eyelashes this way is because there is gentle agitation to the eyelids to break any of the dead skin cells or buildup of eyelash collarettes or anything else. And so now there's some at-home devices used to agitate and clean the eyelids, especially for people with a history of chronic blepharitis or more likely to get it. But there are some devices that are being used in the eye clinic, something we call microblepharoexfoliation. And this is often using pro-type tools that clean the eyelids and, again, cause this gentle agitation. It's kind of like, again, you brush your teeth at home, but then when you go to see the dentist, they do a professional cleaning. It's a little bit more of a deep cleaning. We use different types of cleaning cleansers, and that's one of the benefits of doing this, is just better eyelid hygiene. We want to clean off the dead skin cells, the dead skin oils. And this is usually recommended to do at least once a day. Sometimes in the research, it's recommended to do twice a day, is cleaning those eyelids. The other kind of at-home therapy for Meibomian gland dysfunction, because eyelid hygiene only does maybe so much, at least hopefully reduces the presence of things that can agitate or cause irritation. It's hard to claim that it's going to improve truly what's changing with the oil glands, but this is something that doctors often recommend to help kind of clean things up, prevent future outbreaks, and hopefully prevent it from getting worse. Another one is that of eyelid warm compresses. This is frequently recommended for dry eye for this reason, because heating of those oil glands may help melt the oils within the gland and allow it to run smoother and getting it out of those glands. As the meibum becomes inflamed, the melting point of the meibum increases. And so the normal body temperature and blinking may not allow for those oils to melt and even secrete. So adding heat through the eyelids can melt those oils, and then blinking and ideally even an eyelid massage may encourage those oils to release. This is often recommended to do 5 up to 15 minutes, at least once, sometimes twice a day by some practitioners. This is usually done using various warming compress heatable devices. There's many on the market. We've talked about many of them here on the Dr. Eye Health channel. We even did an episode of the Dr. Eye Health podcast going over some of the science. And so if you want to catch that episode learning more about warm compresses and what kind of compresses are on the market, then I'll again link those up in the show notes for you. But in addition to just melting the meibum, there's also some evidence that it changes the phospholipase activity, maybe changes the blood circulation around the eyelid. It could maybe help manage Demodex, even though it probably won't get rid of them. It may help manage them to some degree, and certainly alleviating symptoms. Again, after heating the oils, it is recommended often to do an eyelid massage. This is gently applying pressure to the eyelid, kind of like you're squeezing a tube of toothpaste from the top eyelid or from the bottom eyelid up. You're trying to express any of the oils that are trapped in there. The challenge to doing eyelid massage, I'll add, is that you don't want to add extra pressure to the eyeball, because you don't want to increase the pressure and risk of glaucoma by pushing on the eye. And for people who are at risk of conditions like keratoconus, you want to avoid adding additional pressure or rubbing of the eye, because we generally recommend people don't rub the eyes. Now, there are some publications on this, and I've done some videos on YouTube kind of showing how this is done, but I encourage anybody who's listening in, if you're going to try this yourself, in fact, it's best to ask your eye doctor what they recommend, or have them even demonstrate on your eye so they can show you by showing you on your own eye, and then you can compare and do it at the same time on the other eye so that you can compare the pressure feeling between how the doctor's doing it and you're doing it. That way you have a better idea of really how much pressure you want to be pushing on that eyelid if your doctor recommends doing these at all. And again, the challenges of warm compresses and eyelid hygiene I'll add in there is the dropout. We tend to see people when we recommend, hey, I want you to start this new habit. It's good for you. It's good for the eyelids and the symptoms and the condition. People will do it a few times and then they forget about it. It falls out of their normal daily routine. But I have had patients who they find that, hey, just with doing compresses alone a few times a day, they don't feel like they need to use eye drops. They don't feel like they need to rely on medications as often. There's a lot of potential benefits for case-by-case basis. And I add that because some people, especially in cases of rosacea that we talked about before, and a lot of people with rosacea tend to have Meibomian Gland Dysfunction, heat can be a trigger for some people to cause worsening flare-ups of their rosacea. So there are cases where warm compresses may not be recommended. And several practitioners in the eye care space have now been recommending cold compresses as an alternative, which sounds counterintuitive. The cold may not melt the meibum, but it does help soothe inflammation and irritation. And so there is that benefit. I've mentioned, again, in our previous breakdown of warm compresses, that with cold compresses, you don't want to go over 10, definitely not over 15 minutes of doing a cold compress, because that can cause a rebound vasodilation, causing more swelling and issues. But again, always talk to your local eye care provider, what they recommend, what would be best for you if you're tuning in. Now, there's also some recommendations by experts and what's in the research around using dietary or supplements to help with the Meibomian gland changes. This is theoretically not going to change the blockage of the keratinization of the epithelial cells, but this may change the secretion from the meibocytes, so changing the inflammation of the oils in the first place. The biggest concentration in the research is that on omega-3s from either eating oily fish and getting omega-3s naturally in the diet, or taking omega-3 supplements. I'll add that the research on omega-3s, specifically in the area of dry eye, we've done whole videos, even a podcast episode previously, bringing on some experts in this area, that in the dry eye space, there still is quite a bit of debate around omega-3s. And a lot of the research, I will say, is just muddy. Not all the research uses the same concentration or milligrams of omega-3. They don't always use the same type of omega-3s or ratios, and they don't always measure the same tear film parameters throughout that research publication. So it's sometimes hard to compare apples and oranges. However, some of the more recent publications, large clinical reviews, do note that Meibomian gland secretion is largely found to improve with supplementation of omega-3s, and that general eye health, somewhere around 1,000 to maybe 1,500 milligrams a day, may suffice, especially if it's with a diet that's paired with a diet that does have omega-3s in it, eating fatty fish like salmon, mackerel, sardines. But I will also note that some dry eye specialists do recommend somewhere closer to 2,000 to 3,000 milligrams a day of a ratio of like 1-to-1 or maybe 2-to-1 higher EPA to DHA for omega-3s. I'll also add that you don't need to go with purely fish oil if you're somebody who's allergic to fish or sensitive or for ethical reasons wants to avoid fishing practices. There is algal oil that's available as well. There's not as much research on algal oil specifically for dry eye, but that is an alternative that people can think about. As always, with all supplementation, I do recommend talk to a provider regarding any interactions with medications, any other health effects or concerns that they may have. There's not as much control or research, I can't say research, but there's just not as much quality control around the supplement market as there is around things like pharmaceuticals. And so there's always some words of caution with supplementation. Now, we've talked a lot about different at-home therapies. There's even more. There's a lot of different recommendations in the literature around things like cosmetics or reducing screen time in front of computers, different dietary habits, contact lenses. There's a lot of different things. I just want to give note that it's largely to try and reduce systemic inflammation throughout the body or anything that irritates the ocular surface. That is something that a lot of eye doctors are recommending and is now kind of being a hot spot of discussion in the eye care field, especially in dry eye in the ocular surface. Now, going back to just meibomian gland dysfunction, let's talk about the advanced treatment options. Like when you see the doctor, you've tried other things, beyond just what you can do at home, what type of medications, what therapeutics, what procedures do doctors often recommend to have the best results for meibomian gland dysfunction? So there are some procedures that are offered in the clinic. Not all eye clinics will have these procedures. If they specialize more in ocular surface, dry eye, they may have them available. One that I think a lot of practitioners do recommend and hold in high regard, specifically for meibomian gland dysfunction, is that of a light-based therapy called intense pulsed light, or IPL. Again, we've talked about IPL in previous episodes. Again, we'll put everything, more resources in the show notes for you if you want to learn a little bit more. Intense pulse light is using broad band wavelengths of light, meaning there's not just one wavelength, there's multiple wavelengths of light treated in a very intense energy in a very localized spot treatment, usually treating the whole face and around the eyelids. But intense pulse light will photocoagulate or kind of burn off those small irregular blood vessels that are often feeding inflamed mediators to the tissues that are exacerbating meibomian gland dysfunction and symptoms of dry eye. So IPL is often utilized for that. Another light-based therapy that is getting more traction and interest in the research is that of low-level light therapy, also known as photobiomodulation or red light therapies. Again, we've done some previous episodes talking about that, and we'll again include those in the show notes. That, I will say, is associated with some improvement of tear film parameters, tear film stability. There's a lot of different instruments in that area, and the research, I will say, is still a little bit mixed, but that is getting some attention. Historically, thermoexpression devices have been used. Again, like we were just talking about the warm compresses that are often recommended. That's adding heat directly through the top of the eyelid to heat up those oil glands. In the eye clinic, there's various instruments, but they heat the oil glands through different methods, either from the front side of the eyelid, but also oftentimes from both sides of the eyelids, inside and the outside, so you get more of a uniform heating. They bring the heat up to the melting temperature of the meibum that's been found and studied. And then after they've melted the glands, then there's a compression, either manual or automatic through the device, where the compression expresses the now melted meibum out of those glands. In some procedures, doctors will come in after the fact and use an expressor tool like I showed earlier with the meibomian gland expression and then express the meibum. Again, there's different procedures for this. Research largely shows that it is very positive, but again, you have to talk to the eye doctor what procedure they have, what instruments they have. Something that is getting a little bit more attention as a newer treatment option in this same kind of category is that of bipolar radiofrequency. This also heats up the eyelids and specifically the oils in the meibomian glands. It also has a small traumatic effect on the dermal tissues of the eyelids in a positive way, because when it stimulates the dermal tissue, it helps produce more collagen. So it helps with collagen formation. And so there is some benefit there with bipolar radiofrequency. But again, after that procedure, the meibum is melted, so the doctor has to come in and manually express those glands. Two other kind of procedures that are sometimes found alongside these other ones that we just mentioned, whether it be light-based therapy or heat-based therapies, this is eyelid debridement, and another one called Meibomian gland probing. Now, eyelid debridement is because when there's keratinization, this buildup of dead kind of fibrous tissue along the margin of the eyelid, that may be blocking or capping off those glands. So the doctor may use a tool to scrape that excess tissue off, this fibrous tissue away from the eyelid margin, exposing the Meibomian gland orifice so that the oils can even release. Sometimes those glands are completely blocked off. The gland may be alive on meibography, but the orifice is plugged. And no matter how much heat or pressure we put, we cannot get it to express. And so in those cases, a procedure called Meibomian gland probing will use a very microscopic type of needle probe to puncture through that now clogged gland orifice and open it up again. I will say this is not accepted by all practitioners. They do need specialized probes, which had been discontinued for some time. There's a new version that is now available, something I'm actually interested in learning more myself. This can be uncomfortable sometimes for the procedure, so oftentimes a numbing agent is applied, an anesthetic. There is a famous doctor named Maskin who's quite famous for kind of starting and pioneering this procedure. And my hope is that at some point, especially if people are interested, I'll be able to recruit or ask Dr. Maskin to come on as a special guest in future episodes to talk to us more of how he manages Meibomian gland dysfunction and utilizes Meibomian gland probing in his practice. Some more advanced treatments that may not be completely FDA approved for the treatment specifically of Meibomian gland dysfunction, but may be utilized off-label by practitioners are those of prescription anti-inflammatory or immunomodulator medications. The whole goal behind this is to reduce any inflammation on the ocular surface, in the eyelids, and maybe in the tear film, as either a way to help settle a flare-up or ideally even maybe prevent future outbreaks or exacerbating other dry eye-like symptoms. There are some neuromodulators, medications that again may be prescribed for treatment of things like dry eye syndrome, but may have evidence to stimulate the sympathetic or parasympathetic nervous systems to help release and get those glands, your brain to send a signal to those glands to even release and produce the oils. There are use of prescription antibiotics, especially in the case of things like Blepharitis related to Staphylococcus aureus, or in the presence of Demodex, they may prescribe medications or procedures to get rid of things like Demodex. But sometimes oral antibiotics may be used or prescribed, not for their antibiotic effect, helping Meibomian glands, but for an anti-inflammatory effect that some antibiotics may have for changing the oil secretions from the skin. I will say, while this has been a longstanding practice in both dermatology and optometry and ophthalmology, there is a bit of discussions around the concern of oral antibiotics' effect on the gut microbiome. And so some practitioners I find and talk to are largely steering away from using these oral antibiotics for this reason. But it is still something that's technically in the literature, and there are still some professionals who find great success with it. So something to, obviously, if you're listening in and you want to learn more about this, talk to your eye doctor about what they think is best for you in your case. And then we have lipid layer stabilizers. And I put this in here because these are often now utilized to help with symptoms of tear film instability and dry eye, but they don't necessarily have a therapeutic effect on the Meibomian gland dysfunction itself yet. Literature is still kind of looking more into what, if any, positive effects on the glands themselves. So those, of course, are the current treatments that are available. There are some new treatments I'll mention that aren't listed here that are either just emerging treatments, whether they be therapeutics in their phase 2 or phase 3 clinical trials, but also some procedures that I know have been available for about a year or two that haven't been widely accepted yet, but may change the for lack of a better term, biofilms or microorganisms that may be living on the eyelid surface or within the meibomian glands themselves. It may change the consistency of the meibum secretion. So this is something myself and other practitioners in the space are always paying attention to what's working, to what has proper evidence, and then kind of what we can better offer our patients to not only help with symptoms, but hopefully help prevent future issues and worsening disease. Now, the final thing, because we've talked about a lot. Today we've covered not only what meibomian gland dysfunction is, the pathology of what's changing to the glands themselves, to potential causes, what could have led to the development of meibomian gland dysfunction in the first place, and then all of these different treatment options. I do want to end with just encouraging that if you're tuning in, don't just take my word for it, right? Everything that we talk about here on the Dr. Eye Health show, the podcast, is always rooted in evidence, and we try to keep it just always in your best interest. And you can't just take my word for it. You can't just search online and hope to get a diagnosis or get proper treatment. It is by far the best to go in to see a professional, especially if somebody not only is an eye care provider, but specializes in anterior segment, dry eye disease. They are focused on the surface of the eye, the cornea, because those doctors are going to spend more time evaluating that ocular surface. They're going to evaluate the tear film, the tear volume, how stable the tear is, if there's inflammation present. They're going to measure the meibomian gland status and the function. They'll even test for sensitivity of the cornea and how well your nerves are picking up that there is damage or that there's something irregular going on in the ocular surface. That's something we didn't talk about too much in this episode, but we have covered in previous episodes on the Dr. Health podcast and the show. And these doctors are going to be able to review your medications, all the comorbidities, every other risk factor, and give not only a proper diagnosis, but they'll be able to prescribe proper treatments to help guide through that condition. So with all of this being said, hopefully you've learned quite a bit about meibomian gland dysfunction. You feel better armed and ready to ask questions to your doctor when you have an evaluation, and you have a better understanding of what is contributing to not just meibomian gland dysfunction, but dry eye in terms of signs, symptoms, and everything going forward. Hey, I just want to say thank you so much for being here. If you enjoyed today's episode, please not only like, subscribe, and follow, not only here on YouTube, but on your favorite podcasting platforms. And if you want to learn more, we always have additional resources in the show notes. From here, let me just say thank you so much for joining in. Keep an eye on it, and we'll see you in the next episode.
You've been listening to the Dr. Eye Health Podcast with Dr. Joseph Allen. For more resources, trusted information, and helpful tools, visit dreyehealth.com. Thanks for joining the community that's focused on healthier eyes and a healthier life. Until next time, stay informed and keep your vision sharp.